Now we are going to have an online session on movement disorders in children, requesting Dr. Subramaniam to take over.
Introducing Dr. Vijay Palanivel. Sir is a senior consultant in pediatric neurodisability at Children's Trust Hospital, UK. Sir is actually from Chennai, and he has been an advisor to us from time to time and has been a very encouraging senior member of the pediatric neurodisability team. So I would welcome Dr. Vijay Palanivel and thank him for giving us the honor of having him as one of the faculty in our national conference. On to Dr. Vijay Palanivel.
Yeah. Hello. Can you hear me?
Loud and clear. Okay? Loud and clear. Loud and clear.
That's great. Thank you to Dr. Subramaniam for inviting me to present today. So I'm going to share my screen so that you can see my presentation. It says host as disabled screen sharing.
Yes, sir. I'll let you know once we are able to see it, sir.
Thank you.
Allow screen sharing, Paul. Just a moment, sir.
Yeah, no problems. So in the meantime, I'll just introduce myself. And as Dr. Subramaniam said, I'm originally from Chennai, but I've been living in the UK for the last 20 years, except for 1 year, sometime 10 years ago, when I was in Global Hospital as a pediatric neuro rehabilitation consultant. So currently, I am working at a place called the Children's Trust in London. It is the UK's largest pediatric neuro rehabilitation center. And we have referrals and we get children from all over the UK, Western Europe, America, and Middle East. So I'm the medical director of the hospital, and I also work as a consultant in pediatric neurodisability. So I think...
Screen share is enabled, sir. Just check.
Yeah, I can do that. Now, can you all see the screen?
Yes, sir. We can see your screen. It's in, you have to put it in presentation mode, sir.
Yeah, is it in presentation mode now?
Yes, sir. Absolutely. Right, sir. It's in presentation mode.
Okay, thank you. So this is the hospital I work. It is on 25 acres of land. Looks really pretty. And I like to show these pictures always in all my presentations, even if it's in the UK, because it's very unusual for a hospital to look like this. It's like a countryside mansion. So this is what it looks like in summer. And this is our staff barbecue party, where we have it every year for children, young people, families, staff, everybody take part in it. And this is sometime in spring, and this is in winter with snow. So my topic is dystonia updates on assessment and management. And when it comes to pediatrics, most of our dystonia that we're going to see are in the context of cerebral palsy and acquired brain injury. So dystonia, what is dystonia firstly? So there have been many definitions given to dystonia, but in 2014, Albanese and group came up with a definition for dystonia, which is currently still followed. It is a movement disorder characterized by sustained intermittent muscle contractions causing abnormal repetitive movements, postures, or both. And dystonic movements can be typically patterned, twisting, and can be tremulous as well. So it can be like tremors. So I'll show you some videos of what the dystonia looks like. So basically, this means abnormal, tonia means tone. It's a fluctuating hypertonia. And children will be displaying involuntary postures and movements. Dystonia typically settles in sleep. Most of the time, it settles in sleep or at rest and gets triggered whenever the child is excited. So either in arousal or unhappiness, when the child is angry, when the child is crying, when the child is tired, lack of sleep. Whenever the child is concentrating on something, to do something which is quite challenging, it can happen. Emotional states can happen. As I said, the child is unhappy or too happy, the dystonia can be triggered. When the child is hungry, it can be triggered. Temperatures, variations can cause increased dystonia, and even just stimulation, even tickling the child can increase dystonia in a child. And when the child is attempting to do something, the voluntary movement, the dystonia increases. I got a few videos to share, which I will come to it. So dystonia can be either generalized or can be focal or can affect certain parts of the body, which we call as segmental. So this is a video of a child having quite a significant form of dystonia. And as I said, it's different parts of the body all getting excitable at different ways. And you can see the dystonia is affecting the arms, the legs, the neck, the face, the tongue, the eyes, It's quite a significant dystonia, and this is the life of a child with dystonia, with severe form of dystonia, and this is how the child is from the time the child is awake till the child goes to sleep. It's quite challenging for the child and quite painful as well sometimes. And this is a video showing tremors in this dystonia. Clinic, we all meet. So I'll play this video once again. It's a very short video. You can see the shaking of the hand. So it's just in this clinic, we all meet. So it isn't like an intentional tremor that we see in cerebellar conditions. So whenever the child is attempting to do something, the tremor kicks in. And then we have this worst form of dystonia, which is status dystonicus, just like status epilepticus. This is a clinical emergency. It's a dystonic storm. The storming starts, and the dystonic symptoms rapidly intensify to extreme and repeated contractions. So this is a video of a child in a dystonic crisis or a status dystonicus. You could see the pain the child is in, see the face. And the dystonia is affecting the face, the tongue, the eyes, the arms are all in flexed position. It's quite a painful condition. And sometimes we see children curled up like a banana, either or hyperextended like a banana. So when it comes to assessment of dystonia, we need to look at various parts of it. So firstly, there is this associated reaction.
Recording in progress.
Are you able to? Yeah. Are you able to see the screen? Yeah. So we call this as overflow of dystonia. So when it comes to assessment, there are certain terms that are being used. It's overflow. The therapist would call it as associated reaction, which means that when the child is trying to make one movement, other parts of the body involuntarily start to move. And that's a classic feature of dystonia. So you see this video. This is a young person currently at the Children's Trust getting neuro rehabilitation with me in our hospital. So you could see that the young person is being asked to move the right arm, and you can see the left leg going up involuntarily.
Where are you going? Sing at my soul.
This is a 16-year-old girl who sustained a cardiac arrest when she underwent colonoscopy and ended up with hypoxic ischemic brain injury. So the young person is now moving the right arm, and you can see the right leg is going up involuntarily, which is not in our control at all. And then the left arm is going into a flexion, the neck has gone into a flexion. So this is called overflow pattern of dystonia. Moving one arm or one leg moves the other parts. And then there is another feature of dystonia which is called co-contraction, which is where the agonist muscle and the antagonist muscle of a joint, they move all together. So when we want a normal movement to happen, the agonist muscle acts, the antagonist muscle should actually calm down. But in dystonia, both the agonist and antagonist muscle start to work together, giving a feature of co-contraction. However, this is not always abnormal. So in the normal, it can be a normal early developmental finding. So for example, if a child is learning to walk for the first time, you will notice the child has got a triple flexed position, where the child is flexed at the hips, at the knee, at the ankle, and giving a co-contraction pattern. So this is a video of my son, who's now 7, but this is when he first started to walk.
You're walking.
So it's called Narayan Krishna.
Look at you walking. Vijay, he's taken about 20 steps.
And you can see the position of the hips, the knees, the ankle, even the foot. It's all contracting at the same time. And it looks like, and this is a feature of co-contraction, and it's a normal developmental finding until the age of 2 years, but in dystonia, it lasts even longer than 2 years. So you could see this is a child walking. He's a 6-year-old child walking, and you could see that he's walking with a very stiff leg. We would have typically called this as spasticity in the past, but this is actually a feature of dystonia, where the child is trying to flex the knee and straighten, but everything's acting at the same time, giving a very stiff knee pattern. And this is the same video, the same person that you saw who's currently in my hospital. So she's been asked to keep her left arm forward by the therapist. And whenever she's trying to do that, the muscles in the back of the shoulder are working equally, the antagonist muscles. So she's not able to keep her left arm forward. It keeps going back. And that's a co-contraction pattern of the upper limb. So all she's need to do is keep the arm forward, and it keeps going back because all the agonist and the antagonist muscles are working at the same time. So this is a co-contraction pattern of dystonia. So dystonia and cerebral palsy, I would say it remains underdiagnosed. If you take a medical textbook and look at cerebral palsy, read about cerebral palsy, this would have been the typical classification would have been given. Spastic cerebral palsy, 85%, dystonic cerebral palsy, 14%. But I would say that this percentage distribution is still not correct because dystonia and cerebral palsy has been underdiagnosed for a long time. When somebody calls it as spastic cerebral palsy or spastic quadriplegia, there is a lot of dystonia in it as well. There could be spasticity, but there's a lot of dystonia. But we give the more focus on spasticity rather than the dystonia. And the problem with this is that I'll come to when it comes to management, the medications that we use are completely different for dystonia to spasticity sometimes. So there was a study done in 2017 looking at what is actually the pattern in the so-called spastic quadriplegia. And if you notice that in the upper limbs, the dystonic pattern is actually more than the spasticity pattern. So the dystonia ring is the green color ring and the red color ring is a spasticity. And in the lower limb, the spasticity and dystonia are almost same, at same levels. So is it actually a spastic quadriplegia or is it a condition called mixed tone quadriplegia or mixed dystonic spasticity quadriplegia? Because medications for use in spasticity and dystonia do differ a little bit, and it's very important to not underdiagnose dystonia and cerebral palsy. So how does dystonia impact? It impacts motor function. It causes pain and comfort. You've already seen some videos how it is affecting pain. It affects the ease of care. Caring for the child becomes difficult. Dressing, feeding, positioning. And this is the hypertonia assessment tool. And if you just Google hypertonia assessment tool in the internet, you will be able to find this tool. And it's a very useful tool to distinguish dystonia and spasticity. What is dystonia, what is spasticity, and what is rigidity? And it's a very self-explanatory tool, and it's very easy to use. And with that, using this tool, we can say, is dystonia the predominant issue, or is spasticity the predominant issue, or are they all coexisting in a mixed pattern? So when it comes to treatment of hypertonia, I just added a bit about spasticity as well because there will be some reference to management of spasticity. But when you look at scientific research in management, drugs used to manage dystonia, there are very few studies, and even the studies that exist are poor quality and poorly designed studies. So basically, I mean, when it comes to dystonia, there are not many studies at all with medications. So is dystonia management evidence-based? Probably not, because there's not much evidence available in literature. Is it experience-based? Yes, we go by learning from other experts that we work under, or over the period of time, we develop experience in using these medications, and we kind of come to know what works and what doesn't work. So when it comes to using medications to managing dystonia, or generally hypertonia, this is the issue. In my earlier slide, I said dystonia gets worse with pain. It can get worse with reflux. It can get worse with constipation, urinary retention, confusion, vomiting, and the issues about dystonia again are poor medication absorption. But when you look at the side effects of the medications that we use to treat dystonia, the side effect pattern is exactly the same as what actually causes the condition. So here we go, we have a problem. We're using medications, but the side effect of those medications can be triggering dystonia rather than treating dystonia. So this makes management of dystonia with medications even more challenging. So the general rules are start at the lowest possible dose that works, then titrate the dose up slowly if needed, keep assessing the child regularly, and if the medication is not working or if there are any side effects, we need to look at withdrawing, but in a slow way rather than just stopping abruptly. Wean slowly and stop. So first medication, baclofen. So baclofen, we know we use it commonly in spasticity. It can be used in dystonia as well. So it works by activating the GABA neurochemicals in the brain, thus causing inhibition of the tone. So evidence, there's not much studies done in baclofen in dystonia, but as through experience and through expertise, I use this baclofen for managing generalized dystonia and cerebral palsy, particularly when the dystonia is causing pain or limiting activities. The side effects are quite large. Sedation is an issue. It can cause confusion. One of the issues with baclofen is that it not really reduces the tone in the limbs, it reduces the tone in the neck and the trunk, causing truncal hypotonia and poor head control. So that is a major issue of baclofen. It can increase drooling, it can increase dysphagia, it causes urinary retention, it can cause constipation. And as I said earlier, all the side effects described here can also be triggering factors for dystonia. So is baclofen actually going to be working for dystonia or making dystonia worse? So that's why I say start at a low dose, keep increasing and keep assessing. If there are any side effects, if the dystonia gets worse rather than getting better, then it's time to consider weaning and stopping. The other medications which can be used for dystonia, benzodiazepines, so clonazepam, diazepam, and lorazepam. It's a GABA receptor agonist as well. Evidence in literature, not many, but through expertise, we would say that it could be used for managing dystonic storms, status dystonicus, and also for short-term management dystonia. It's not a drug we should be using in the long term, and the reason is it causes high level of sedation and can cause tachyphylaxis. That means that the dose gets no longer, the dose at which the child is on, it doesn't no longer works, develops tolerance, then we keep increasing the dose, and that can cause a respiratory depression. So it's used for short-term management of dystonia. The other next medication is clonidine. As we know, clonidine was originally invented or originally found for to be an antihypertensive agent. It's an alpha-adrenergic agonist, and it has been used in other neurodevelopmental conditions like tics and ADHD. It can be used for sleep disorders. But clonidine started to be used in dystonia going back in 2007, 2008. And in the UK, me, myself, and some of my colleagues were the pioneers in trying clonidine in dystonia. We started using it firstly in PICUs, in ICU settings, rather than in a general ward or in the community, particularly for dystonia, which was causing extreme distress, extensive posturing, undirected thrashing of the limbs. How clonidine works for dystonia, we don't know. Is there any evidence in literature? No. Expertise? Generally, we advise not to use it in the community. It is a medication which is started during the acute stages in hospitals, or can be used in ICU settings or HDU setting, or at least in an acute setting in a ward. But we wouldn't be wanting to use clonidine when the child is in the community, particularly at doses that is used for managing dystonia. Side effects could be bradycardia, hypotension, and sedation. The next drug which came into fashion is gabapentin. It's an analog of GABA. We know GABA agonist of GABA receptors helps with tone. So we thought, okay, why not go for the B drug, gabapentin, which is an analog of GABA. It was originally an anticonvulsant used for neuropathic pain widely. How it is controlling dystonia, we don't understand it much. There is some evidence in literature, but not many children in the studies. Only 25 of the children in the study had cerebral palsy. And what the experts say is that it can be used in dystonia, particularly if it is with pain and spasms. And I've been using gabapentin quite a lot for the last 10 years now, and I see good results with it. But it's very anecdotal. It's just my own experience. Side effects: drowsiness, abdominal pain, constipation, dyspepsia, movement disorders. Gabapentin is a drug which can induce movement disorders such as tremors and twitching. It can cause nervousness. It increases appetite and weight gain. The next drug is levodopa. Levodopa can be used in a particular condition called dopa-responsive dystonia, which is a genetic condition rather than associated with cerebral palsy. So the experts all decided, okay, if levodopa works in one part of dystonia, why not try it in cerebral palsy as well? And it has kind of worked, may not have worked, and it's not that effective. And the main problem of levodopa is that it itself causes dyskinesias, which is unpleasant. Then the other drug came into fashion is trihexyphenidyl. That's going on for the last 15, 20 years now. And it is an anticholinergic drug. We know that. Mechanism, how it helps dystonia, we don't know. Evidence, 2 studies were conducted. One of the studies I was involved in it. It's a very small pilot study, and it showed some low-level evidence. And the study basically concluded it's not effective. But I do use it in I use trihexyphenidyl, particularly when there is a dystonia affecting more the peripheries than proximally. Like the tremor video I showed, I typically try trihexyphenidyl for that child who has a tremor. And the results, what I've seen is that it works in maybe 40-50% of the times we tried. And the side effects are all the anticholinergic side effects: dry eyes, dry mouth, blurred vision, constipation, urinary retention. Interestingly, trihexyphenidyl causes emotional lability. And I had some children who were given this medication and come back with kind of mental stress, psychiatric-like issues, basically emotional issues, and I had to stop the trihexyphenidyl as a result. Now, botulinum toxins, Botox. It's widely used in spasticity. Can it be used in dystonia? So we all know how it works. It works by inhibiting the release of acetylcholine at the neuromuscular junction. And this is a simple depiction of how it works. The acetylcholine receptors are necessary. The acetylcholine release is necessary for muscle contraction. Botox or botulinum toxin goes and binds with all these vesicles which has got the acetylcholine, stops the release of acetylcholine. So there is no acetylcholine at the neuromuscular junction and the muscle contraction doesn't work. But Botox has to be used with caution. Just a bit of trivia. The 5 deadliest poisons in the world, one is called ricin, which is from rice, VX, which is a nerve agent, which was used to kill some spy agent or somebody by Russia in 1978. Batrachotoxin, that is a toxin derived from plant. Number 2 is mycotoxin, which is derived from shellfish. And the world's most deadliest poison is botulinum toxin. So when ingested in even a very small amount, it can cause death, even in the largest mammal of the world, which is blue mammal. So it's the world's deadliest poison, and hence botulinum toxin has to be used with caution, particularly when we are injecting it into muscles and very close to the blood vessels. So this is basically from Clostridium botulinum. There are 7 natural phenotypes available, but there are only 2 phenotypes, A and B, which are commercially available. So the drug which is the most commonly used toxin is Botox. This is available in India as well. The European brands is something called Dysport, and then we have Xeomin, which I understand is available in India now. So is there any evidence for using botulinum toxin in dystonia? Very inadequate data. But I do use it in managing dystonia, particularly when there is focal dystonia or targeting specific muscles in a generalized dystonic condition. The peak effect of the toxins when once injected is 2 to 4 weeks, and the chemical effect lasts for 3 to 4 months. And I always use ultrasound scan for injecting botulinum toxin. The reason is in children, the muscles are small, and in children with cerebral palsy, the muscles are not the same. They don't look the same, they don't behave the same, and they could be even wasted. So we might be thinking that we are injecting into some muscle, and we may be giving the injection right into the, again, antagonist muscle or the opposite muscle, or going deep, or maybe hitting the nerves, or could be hitting the blood vessels. So the advice generally is to not use botulinum toxin injections, the world's poisonous toxin, without ultrasound guidance. What the ultrasound offers is that we can see the muscle, we can see the needle going in, we can see the tip of the needle, and we can see the injection being given in that particular muscle where we want to give it. So this is the video of a child receiving botulinum toxin. And the plan is to give Botox into the adductor magnus, and you can see the needle going in straight into adductor magnus. It's live, we can visualize it. You can see the tip of the needle, and when the injection is given, you can see a white blob, which is basically, we know that the injection has been given in the right muscle. This is Botox given to medial gastrocnemius. Once again, you can see the needle going in, the white needle. And the tip of the needle is in the medial gastroc, and when it's given, you can see a blob that the injection has been given. So the side effects of Botox is painful. It can cause excessive weakness, particularly if it's given into the wrong muscles. It can cause flu-like symptoms for 2 to 3 days after the injections. If it's given in the wrong place, or if it starts to spread through a blood vessel by being given into blood vessel, it can spread to the bladder and bowels and cause bladder-bowel instability. It can even spread up to the muscles of swallowing and cause dysphagia, and it can affect the muscles of breathing and cause respiratory depression. These are rare side effects if given correctly. And one of the issues of giving Botox is sometimes there could be antibody formation. So the second time we give it, there could be a secondary unresponsiveness because of the antibodies present. So this is, in summary, this is the management options available for spasticity and dystonia. There are more drugs for dystonia, but they're all very anecdotal, not many studies available. And too much choices also sometimes is a problem. We don't know what to do with those choices. But at least we have some drugs which can be trialed. And the video, this is the final video, final slide. This is that a same person who had very severe form of dystonia, the 16-year-old, after being in our hospital now for 3 months, and the child received various medications which ranged from gabapentin to baclofen to clonidine, and also had botulinum toxin injections given into more than 18 muscles. This is the result that we have currently with her. So the dystonia is almost settled. She's more relaxed. She's able to sit even in a very poorly positioned chair, and she is able to follow any commands. Move the neck. The neck has been sorted. She looks much happier, less in pain. The arms and legs are more relaxed. But this took us nearly 2 months to get to this position by trialing various medications and also by injecting botulinum toxin injections into various muscles in her neck, shoulder, upper limbs and lower limbs. So the control of the arms have increased. There is no overflow movement as I showed earlier. There's a little bit of co-contraction still on the left upper limb, but it's much better. Previously when she moved her right arm, her legs were moving, but now the legs are all very still and relaxed. The young person is now able to walk using a walker. She is able to dress herself. She is now trying to feed herself as well. Thank you.
Thank you, Dr. Vijay. It's indeed a great talk, especially on a difficult topic like dystonia. And it is really magical to see the child in the child's progress. Ending with that note that this is a topic, this is a subject, or this is an area where there's not much of clearly evidence-based management that is there. But with a minimal amount of experience, with good amount of experience, and with the little evidence that we have, we can make their life better. I'd invite any questions, if there are any, from the floor. You can hand over the questions to me because he's on Zoom. It will be very difficult. Are there any questions from the floor? So I don't think there are any. Thank you, Dr. Vijay, for joining all the way from UK and giving us this beautiful lecture. We will send your certificate across by email, of course. And next time you come to Chennai, we will definitely meet up. Do you have any?
Thank you so much. Thank you so much for the invite again and the opportunity.
Thank you so much.
All. See you.
Have a great day.